Welcome, everyone. Thank you for joining us for our webinar this afternoon. And I'm just thankful that you were able to join us. We have a great presentation today about measles and what healthcare providers need to know. And with Ashlesha Kaushik, who is, we're very grateful to have join us today and be able to present for us. So before we get started, I just want to give you a little information to remind you that we do have CME available for this webinar. So you will be receiving information about that after the event. And also just want to let you know disclosures. We do not have any conflicts to disclose at this time. So like I said, we have Dr. Kaushik here to present to us. As you can see from her credentials up here on the screen, where she is very active and very involved in infectious diseases. She's a medical director of UnityPoint Clinic, the pediatric infectious disease. And she's also the director of the Antimicrobial Stewardship program and the chair of the Pharmacotherapeutics and Nutrition at UnityPoint. She's also a clinical assistant professor in the Department of Pediatrics at University of Iowa, and also the resident preceptor at the Siouxland Medical Education Foundation Residency program. In addition to that, there's many more things she's involved with, but also where I get to work with her most is actually through FAAP, where she is an Iowa chapter board member, actually incoming vice president, and also a national spokesperson for the immunization. And also very active within the CDC Project First Line as an ambassador for Iowa. So really I'm grateful that she is here and able to present for us. And as I switch it over to Dr. Kaushik, she's going to share her screen. And I'll just let you know that she's going to present, and then at the end we'll have time for questions. So you can either write questions in the chat, or you can at the end raise your hand and unmute yourself, and we can do that. So I'm going to turn it over to you, Dr. Kaushik.
Thank you so much, Laurie. Thank you so much, all of you, to be attending this. I am so honored to talk to you today about measles, what healthcare providers need to know. And so today's objectives will be to discuss clinical considerations for measles, including the clinical presentation, diagnostic criteria and measures, as well as management for measles. Also to discuss the epidemiology and the current status of measles in the United States, and to describe CDC and the Project First Line infection prevention and control guidelines, treatment, as well as vaccine recommendations. So to acknowledge, Project First Line is a national collaborative led by US CDC, and it provides infection control guidance to all frontline healthcare providers, and AAP is a proud partner. And it is very active in putting forward infection prevention and control guidance for various infectious diseases. I have no disclosures relevant to this talk. So measles, and it's pretty intriguing that we are still talking about measles today, but it's in face of the resurgence that we are seeing. So it's the need of the hour that we talk about measles, but again, it's not over, it's not gone. It should have been, but unfortunately, we are still talking about it. So what is measles? Measles is an acute febrile rash illness. It is one of the most contagious of all infectious diseases, having an attack rate of 90%. So up to 9 out of 10 susceptible people will get infected if they are in close contact with a measles patient. The virus is an RNA virus, and it is transmitted by direct contact with infectious droplets or by airborne spread when an infected person breathes, coughs, or sneezes. And the measles virus can remain infectious in the air for up to 2 hours after an infected person leaves an area. So highly contagious disease and very easily communicated. Also, the population immunity of more than 95% is required to stop ongoing transmission. So measles has an incubation period of 10 to 14 days. The range is 7 to 21. So usually 10 days is the incubation period to develop the prodromal symptoms. The prodrome usually lasts for 2 to 4 days and is characterized by the classic 3 Cs, cough, coryza, and conjunctivitis. Also by coptic spots, which are bluish white spots seen on red base near the lower molars, and it usually occurs a few days before the rash onset, and very high fevers. The rash, which is the characteristic maculopapular rash, descending rash, covering palms and soles, it begins approximately 14 days after exposure and classically begins at the hairline and then spreads downwards. The rash onset date is day 0, and the infectious period is 4 days before through 4 days after rash onset. So these are some of the classic pictures as taken from the CDC and the Red Book, American Academy of Pediatrics. And as we can see, the rash is pretty characteristic of measles. The children can get very sick from measles, and it's just not a febrile rash illness. It's just not a simple rash illness. It can lead to several complications. Diarrhea and otitis media are the most common complications, and pneumonia is pretty common too. Measles can lead to hospitalization and death, and because of neurological and respiratory complications, the death rate is around 1 to 3 per 1,000 cases. The neurological complications are many. The most common is encephalitis, which occurs in 1 per 1,000 cases. And there are rarer neurological manifestations, but which are very, very severe. One of them is subacute sclerosing panencephalitis, SSPE, which is a rare neurological complication. It is devastating, uniformly resulting in death. And it occurs approximately 7 to 10 years after infection. And the incidence rate has been described to be classically between 4 to 11 per 100,000 cases. The complications are usually more commonly seen in children less than 5 years, as well as adults more than 20 years. And certainly pregnant women and immunocompromised patients are considered to be high-risk categories. So I was mentioning the neurological complications. So neurological complications also include ADEM, which is acute disseminated encephalomyelitis, and also measles inclusion body encephalitis, which is actually subacute encephalitis occurring more commonly in patients with some kind of immune system disorders, usually begins within 1 year of infection. And the ADEM actually begins earlier, like within days to weeks. But as I was mentioning, the subacute sclerosing panencephalitis is the most serious, devastating degenerative disease, which is fatal, and particularly seen in children infected before 2 years of age. And it is considered to be a direct wild-type virus infectious manifestation. So very sad to say, but in the developing world, there are still wards full of children with SSPE. And I have seen some of them, and it is very, very devastating to see these children really suffer like this, just thus really reinforcing the importance of vaccines. So since the measles vaccine was introduced and in the 60s, and then the MMR combination came through, and then the 2 doses were introduced in 1989. Subsequently, such a revolutionary decrease in measles cases was seen. In 2000, elimination status was declared for the Americas, and since 2000, measles was declared eliminated from the United States. Since then, the annual number has remained really low, and was as low as 37 in 2004. But recently in 2019, if we recall, there was an increase in incidence, and more than 1,200 cases were recorded. Now, the majority of these people who got measles or infected people were actually unvaccinated, as well as mostly CDC noted that they were traveling. So travelers with measles who are unvaccinated, they are the main that's the main cohort, which is continuing to be infected. And then that is the reason to spread measles in the United States in a population in which the population immunity is less than 95%. Measles can spread when it reaches a community in the US where groups of people are unvaccinated. And of note, measles is still common in many parts of the world, including Europe, Middle East, Asia, and Africa. So according to the latest guidance, CDC has said that it is critical for all international travelers to be protected against measles, regardless of their destination. This is a change from 2019 guidance where they said, we should see what destinations are having a high rate of measles and then make sure that you have up-to-date vaccination records for measles. However, now it is critical to note that all international travelers are advised to be fully up-to-date with their measles vaccination. So if we look at the measles cases in 24 by age group, as of last week, total of 132 cases have been reported. And as we can see, pediatric age group really accounts for the majority. We do have majority in unvaccinated hosts. And if you look at hospitalizations, then 53% of these cases have needed hospitalization. And as far as the age group breakdown of the hospitalization, nearly 64% of all under 5 years of age have required hospitalization. So a total of 132 cases have been reported from 21 jurisdictions. Iowa is luckily not yet had a case till now. In 2019, we did have. But we should note that our close neighbors do have cases. So we have to be very cognizant of the fact that certainly the state lines, can be crossed, and all the more need to keep our vaccination status up to date for all our patients. This is just to provide a highlight that there have been 8 outbreaks reported this year compared to just 4 outbreaks last year. And we have already surpassed the case count of since 21 to 2023. So according to the CDC and state health department statistics, this is the MMR coverage nationally. So as we can see, pre-pandemic, it was around 95%. And then, 93% has been over the past few years. For Iowa, the rate has been, was in the high 80s and then falling to like 83 and 84%, which is kind of a little bit concerning. And we must remember that measles, the ideal herd immunity rate should be more than 95%. So as long as we are in the high 90s, our protection will be optimal for our populations. So that should be our goal. And as you all know, this is just to revise the routine recommendations for the vaccination. So for children and adolescents, it is a 1 dose at 12 to 15 months and a second dose at 4 to 6 years of age. For adults without any evidence of measles immunity, which is defined by presumptive evidence, which is, these are the criteria: birth before 1957, either having lab evidence of immunity or else of disease, or else a written documentation of vaccination. So if an adult doesn't have any, then most of the adults need 1 dose. However, CDC stresses that 2 doses are needed for high-risk adults, at least 28 days apart. And these categories include healthcare workers, post-high school students, as well as international travelers. Now, looking at this list, I think a pretty broad segment of population would need 2 doses. So because international travel is big post-COVID. So I think most of the adults, in my opinion, would be needing 2 doses. What are the travel recommendations? So persons aged more than 12 months without other evidence of immunity should receive 2 doses. So actually, it requires that everybody over 12 months should get 2 doses. In fact, children aged 6 to 11 months should receive 1 dose. Now, if a baby does receive the vaccine at 6 to 11 months, then the baby still needs 2 subsequent doses at age more than 12 months to count towards their completed schedule. So what is the approach to a case of measles? So if we have, suppose in our clinic setting, for instance, a patient comes in and reports exposure, for instance, like hypothetically, then we have to mask and promptly isolate the patient in the room, in a room with the door closed. Ideally, it should be an airborne isolation room, but if you don't have that, then at least a regular room, but a separate room with the door closed is adequate for that time being, and then make arrangements for the patient to be transferred to a locality where you have airborne isolation. Now, to diagnose measles, clinical suspicion is the gold standard, but then if you have to confirm infection, Then you can collect the specimens, and I will explain this in greater detail. And then we have to call our local health department or infection control team as soon as possible to notify them, as well as they will also provide us instructions on where to send the specimens. And then in addition to that, we have to identify who all were exposed, so that who might need post-exposure prophylaxis with either the vaccine or immunoglobulin can be determined. And of course, the exposed people who are at high risk for serious disease, including immunocompromised patients, little infants, like less than 1 year of age, or pregnant women, those are high risk categories. And once you have identified the patient, you have to give them supportive treatment because there's no antiviral treatment available, and also vitamin A. 2 doses have to be given immediately and the next day. So as I was mentioning, diagnosis is mainly based on clinical symptoms and community and epidemiologic exposure risk. But for confirming infections, the CDC recommends that we take at least 2 samples from 2 sites. So detecting measles virus-specific immunoglobulin, as well as taking viral RNA PCR samples from the throat, or the respiratory specimens are usually the preferred specimens. The Red Book also says that urine can be taken. Just that, if you take multiple sources, then that increases the yield of return and increases the possibility of diagnosing correctly. Also, some other means can be used, like a 4-fold increase in measles IgG if it was already obtained previously, and then cell culture, which is not really used much these days. As far as management is concerned, there is no specific antiviral medication for measles. Ribavirin has been used in very, very isolated cases and in highly immunocompromised patients, but there is no FDA approval for the same. The WHO does recommend vitamin A for all children with measles, regardless of their country of residence. And most of the experts in the United States also agree with this recommendation, regardless of their hospitalization status. All children with measles should be offered vitamin A. And it is given once daily for 2 days, starting immediately upon diagnosis and repeated the following day. And this is the dosing according to the age group, the age of the patients. The vitamin A is dosed. And an additional dose of vitamin A should be given 1 month later for patients showing signs and symptoms of vitamin A deficiency. So what are the prevention recommendations for healthcare settings? So our first and foremost priority should be identifying the patient rapidly and isolated, so even if they are suspected, and then adhering to standard as well as airborne precautions, and then management of exposed and ill healthcare people, as well as healthcare personnel, as well as patients. So before arrival to a healthcare setting, ideally, if a patient is being, scheduled for an appointment, then for people showing signs and symptoms of measles, then instructions for arrival should be provided. For instance, a separate entrance to use, and what all precautions to take. For instance, how to notify hospital staff prior to arriving, and also wearing a face mask upon entry. The emergency services need to notify the receiving facility or the accepting physician in advance. And upon arrival to the healthcare setting, utilizing triage stations is highly recommended. Persons with signs or symptoms of measles should be identified rapidly, provided a face mask, and separated from other patients as soon as possible after entry. So as I was mentioning, they should be roomed in a room with a private room with the door closed. Also, we should be facilitating adherence to respiratory hygiene, cough etiquette, like not coughing into the hands, but into the elbows if a tissue, etc., is not available. Ideally, tissues and enough supplies should be available. Visual alerts should be posted, and as I was mentioning, face masks, etc., near the visual alerts should be made available. And also enough hand hygiene stations should be available in the facility. So how would you place a patient? Immediately placing the masked patient in an airborne infection isolation room is recommended. Now, if an AIR is not available, then you need to place the masked patient in a private room with the door closed and transfer the patient as soon as possible to a facility where an airborne isolation room is available. Pending transfer, the masked patient should be placed in the private room and the patient should be encouraged to continue to wear the mask. Now, if it's a small infant or less than 2 years of age, they cannot wear masks. So in that case, as all pediatricians know, we can just lift the blanket a little bit to make like a tent over the face gently so that it's not suffocating to the baby. I mean, it's just allowing some kind of a barrier between the infectious secretions and others. And preferably the patient should be placed in a room where there is a recirculation of exhaust with HEPA filtration. And very important to remember, if the patient leaves the room, after the patient leaves the room, it should remain vacant for an appropriate time, which is up to 2 hours. This will allow for more than 99% of airborne contaminant removal. So the standards as recommended by the CDC are to provide at least 6 or 12 air exchanges per hour for an airborne isolation room. Direct exhaust to the outside, HEPA filtration should be maintained. And also the pressure of the room should be monitored daily. And the room should be closed, usually, when it's not being required for entry or exit. So unnecessarily don't keep the door open. Now, what about the healthcare providers taking care of the patient? So normally, without acceptable presumptive immunity, they should not be taking care of patients with measles. So, but a healthcare provider without acceptable immunity should not be entering the room of a patient with measles. And all healthcare providers that are entering the airborne isolation room occupied by a patient with measles, regardless of their evidence of immunity or their immune status, should use respiratory protection. And that's usually like an N95 disposable respirator or even a PAPR device can be used. But remember that airborne isolation means a negative pressure room, airborne isolation with at least 6 to 12 exchanges per hour and N95 masks on top of it. In addition to standard precautions, the airborne precautions are indicated for 4 days after onset of rash. But for immunocompromised patients, they should be kept in isolation for the duration of illness. And just remember that patients with SSPE are not contagious. And exposed susceptible people, they need to be isolated from day 5 after first exposure to day 21 after last exposure. What about transport? In general, transportation should be limited to absolutely essential procedures. If it is necessary, then the patient should wear a face mask if tolerated during the transportation. And, usually a route should be used where not many people would be exposed to that patient. And if the patient is being transferred out of the facility, then the receiving facility as well as the transport personnel should be cautioned about the airborne precautions, and they should be notified in advance. Visitor access is generally not really advised, so it should not be encouraged. So we have to limit visitor presence in rooms of patients with known or suspected measles to those who are absolutely necessary for patients' care. And those without acceptable presumptive evidence of immunity should ideally not enter the patient room. It has not really happened on a large scale over here in our state, but if measles really start circulating in the community on a large scale, then we have to start considering screening of visitors for signs and symptoms of measles before entering facility, much like we did for COVID. So what about the post-exposure prophylaxis? So people that are exposed to measles who cannot readily show that they have evidence of immunity, then they should be offered post-exposure prophylaxis or else should be excluded from the setting, like school, hospital, or childcare. To potentially provide protection or modify the clinical course, either MMR vaccine within 72 hours of measles exposure or immunoglobulin within 6 days of exposure are recommended. Do not give MMR vaccine and immunoglobulin simultaneously, as they do not work well together. So it's either of the two. And the immunoglobulin is usually preferred for immunocompromised patients, for pregnant women, and for infants less than 1 year. So for healthcare personnel, we have to ensure that all healthcare personnel have presumptive evidence of immunity to measles. To remind you, it's either a written documentation of vaccination or else lab evidence of immunity or disease if they are infected or birth before 1957. Now, in cases of outbreaks, 2 doses of measles vaccines are recommended for all healthcare personnel, regardless of the year of birth. Even those before 1957 will need 2 doses of the vaccine during outbreaks. So what about asymptomatic healthcare personnel with presumptive evidence of immunity? So if somebody has had the vaccination and they were exposed, and then post-exposure prophylaxis would not be necessary in this setting, and work restrictions are also not necessary. All we need to do is to implement daily monitoring for signs and symptoms of measles from 5th day after first exposure through 21st day after their last exposure. If they do develop signs and symptoms, then they need isolation. But short of that, they can return to work and they don't need any prophylaxis. What about a healthcare provider if they get exposed and they don't have evidence of immunity? So then in that case, either MMR should be given within 72 hours or immunoglobulin should be given within 6 days. At the same time, we also have to exclude the healthcare personnel irrespective of the post-exposure prophylaxis. And they have to be excluded from day 5 after first exposure to day 21 after last exposure. So to simplify, they have to be isolated for 21 days at least. So, and if a healthcare personnel develops infections, so they show signs of fever and rash, then they have to exclude from work. They have to be excluded from work for 4 days after the rash appears. For immunocompromised healthcare personnel, they have to be excluded for the duration of the illness. So MMR vaccine can be given for post-exposure prophylaxis. It has to be administered within 72 hours of exposure. Anybody who gets the vaccine may return to normal activities immediately, except for healthcare settings. So if a healthcare worker receives the post-exposure prophylaxis as MMR vaccine, they still have to isolate if they did not have presumptive immunity. But except for that, everybody else can return. But you still have to monitor for symptoms. And actually, it can be given to anybody as low as 6 months of age. For immunoglobulin considerations, they have, if you can't give the vaccine, then you have to administer immunoglobulin within 6 days of exposure. The recommended dose is 0.5 ml per kilo, and for the IVIG can be given at 400 mg per kilo. The recommendation for immunoglobulin is usually reserved for the following groups, where there's a risk of severe disease and complications. So for infants aged less than 12 months, pregnant women, and severely immunocompromised patients, including HIV and cancer patients. For the pregnant women and the immunocompromised patients, IVIG is usually preferred. For younger infants, the IM form can be used. So also we need to remember that if somebody has received immunoglobulin, they cannot receive measles vaccine right away. The measles vaccine has to be given at a certain interval. And so if somebody received IgIM, that is intramuscularly, the immunoglobulin, then we can wait for giving the vaccine for at least 6 months. Somebody received IVIG, then the recommended interval to give the vaccine is 8 months. So what about reporting? So measles reporting within facilities and to public health authorities is a must. It is definitely publicly, a notifiable disease. And immediately, as soon as you suspect measles in a patient, you need to notify the public health department, infection prevention control authorities of your hospital as well, because they will not only triage they will provide directions as to diagnostic samples, etc., where to be sent, as well as they will also help in conducting the exposure analysis, like who else is exposed and who needs the post-exposure prophylaxis in that setting. And that's the main reason why we need to notify them in order to prevent healthcare-associated transmission. So with that, I would really like to emphasize that providers need to prioritize measles on the differential diagnosis for any patient that has a febrile rash, who's unvaccinated, who has recently traveled and may have been exposed to a case or an outbreak, and especially with the recent cases occurring in shelter areas, for instance, in Illinois. We need to really keep our eyes and ears open for that and keep a low index of suspicion. Also, we need to really have our high index of suspicion in this case, and providers should ensure that patients traveling internationally need to be vaccinated against measles. This has changed from the 2019 recommendations, and this has to be made sure anybody who's traveling, irrespective of the destination, they need to have evidence of immunity. So they need to be made sure that most of them, even the adults, need to have 2 doses of the MMR vaccine. And for the 6 to 11 months old, also, there's an opportunity to give them the first dose of 1 dose of MMR vaccine for that age group. Community vaccination remains the main prevention strategy for all settings. So again, just preaching to the choir, I think this group is very well aware of pediatricians that we need to have vaccination rates high in our settings, and that will be the main preventive strategy. If there is a very high herd immunity in the community, there's very, very low chance of getting measles introduced in that community. And of course, if somebody does get exposed to measles and somebody does get infected, then we need to rapidly identify such patients, and immediate isolation is what is recommended with a mask on the patient. And the healthcare provider that is taking care of the patient should ideally be vaccinated and then should be wearing N95 regardless of their vaccination status. And as soon as possible, the patient should be transferred to a facility which has airborne precautions. And we need to have standard and airborne precautions in place for taking care of patients with measles. And if the patient or the healthcare provider have been exposed, then they need to make sure we know their immunity status, like whether they have been vaccinated in the past or not. In that case, we need to offer them post-exposure prophylaxis, and we need to isolate them if they are healthcare providers and they did not have any previous evidence of immunity. These are certain CDC resources, and I would really recommend for you to look at these, and especially for the American Academy of Pediatrics resources. The AAP Think Measles is a one-pager that has been created by the Project First Line team, and we have done that to help providers really look at measles just like a 2-minute glance, and you can put it up as a poster in your clinics, etc. So it's a really neat condensed version of quick facts about measles. And there are again other CDC resources about parent and child care providers, etc., what they need to know in this case. So with that, I would like to thank you for your kind attention, and we'll take questions, if any. And I'll hand it back to Laurie. Thank you.
Thank you, Dr. Kaushik. That one's a really interesting, very timely, and very crucial presentation for all of us. So yes, I'd like to open it up to questions. You can either put them in the chat or you can unmute yourself and ask the question. Dr. Nimas has actually put one in the chat. He asked, what are guidelines for newborns delivered to mothers with measles or suspected measles?
So that's a very interesting question. So again, it will be considered to be like a healthcare setting situation. So in that case, we need to make sure that all the, the patient and, the mom, they are at least an airborne room is provided to them, right? And then the baby will need to be protected. So mom can either give express milk and stuff like that, just like we do for TB. And then the healthcare providers need to wear N95. So it will be kind of, I would think, just like you would treat a mother with TB. At the same time, you would remember that you can encourage, you don't want to not encourage rooming in at all, because as we saw for COVID-19, initially they had recommended that, okay, the mothers and the babies have to be separated completely. So we have to be mindful about does the mom really, need, it's mostly 4 days before to 4 days after appearance of the rash that the mom has to be isolated. And beyond that, they should encourage the rooming in, and they can certainly come and visit. But I think it's just limited to that narrow period of time, unless they have some other underlying compromising conditions. thank you for that. There's no explicit separate guidance provided for that, but at least in our NICU also, they have airborne isolation rooms, and even for like patients with varicella and such, they often practice similar guidelines.
Any other questions? We will put the recording up on the AAP website and also be sending that out to all the attendees today so that you'll have this information to refer back to. Okay, well, I think there are no more questions, but a lot of thank yous in the chat.
Thank you so much. Yeah, thanks.
Yes, thank you, Dr. Kaushik. We really appreciate your time, and we appreciate the time of everyone that's joined us today. So thank you.
Thank you.